is an honor to present our next speaker, Dr. Justin Barad. Dr. Barad is not only a pediatric orthopedic surgeon, but also the CEO and co-founder of Also VR, an award-winning virtual.
In the literature, you can read about it. It's a pretty wild story. So he came up with a system of graduated autonomy where there are different levels. Originally, it was pyramid shape. Eventually, it was adjusted to more of a square where it wasn't like a Survivor where people were actually eliminated every year that weren't sort of up to snuff, which is an issue today. But basically, every year you got a little more autonomy and supervised the year below you, and that is actually how surgical training works today. So it's just kind of interesting to think where this model came from and what things were like at the time. And it worked pretty well up until now and starting to show some wear. I think another thing important to note, I guess the slide is gone, so I'll just talk about 1 second is what does surgical training actually consist of? So I often get a lot of questions around this. So a lot of people ask, well, is this being used in medical school? And you're not really learning surgical skills in medical school. So really towards the tail end of medical school, you're learning anatomy, which is very important, but it's very hard to learn applied anatomy until you're out in residency and in practice. And then you're learning some basic skills like suturing, cutting sutures really mainly. But that's about it. And I think where VR has a role is really around career exploration, but a talk for a different time. Then you're moving into internship and residency. This is typically about 5 years for most surgical specialties, and then additional years of fellowship. And in your internship, you're learning some basic surgical skills. You're learning advanced suturing, dissection, and then as you move into early residency, you're starting to learn procedures. So approaches, bread and butter procedures, and then as you finish up and you become a chief, you're starting to learn advanced procedures and some technology, complex pathology. And then now you're out in practice, and this is actually where you have a disproportionate training burden. So you're actually exposed to a lot all at once because you're trying to figure out, okay, what procedures am I going to do in my practice? And the first part of that is what is even out there, because you aren't exposed to everything that is possible during your formal training. So you're quickly trying to be like, what are patients asking for? What are the options? And then once you figure out what's going to be on your restaurant menu, because you're basically like opening up a food shop, you have to figure out how to make those dishes. So you have to learn to do those. So you're trying to explore and learn a large number of procedures very quickly. And then what becomes this circulating loop is the introduction of new technologies, new pathology you haven't seen before, refreshing old procedures. So training is a lifelong issue that really accelerates once you're done with your formal training and you're out of the nest, so to speak. So what are the dynamics that are sort of driving this and making this a bigger problem? One is there's too much to learn, so accelerating science and technology is spreading us more thin. So we've gone from French Laundry to Cheesecake Factory. You just can't do everything well. So I always tell the story as an extreme example. One day I was eating lunch and we were called by the LA Zoo that their gorilla had a subtrochanteric femur fracture. We asked them several times, you know you're talking to human doctors, right? And they're like, yes, but we need to come down here. So Jabari did great. That was a wild experience. But it feels like more and more we're dealing with gorilla-like situations every day, procedures we've never done before, only do very rarely. Second part of the problem is modern surgery is hard to learn. So newer procedures like robotics and minimally invasive techniques sometimes have 10 times longer learning curves. So we've gone to 10 to 20 cases to more like 50 to 100 as a baseline for reaching basic proficiency. Finally, we lack objective assessment tools. So if you think about it, there's no real way to objectively assess surgical skill or procedural readiness. And in my own career, the one time I really was formally and objectively assessed, I was asked to play the board game Operation and remove a few plastic pieces without buzzing. So seeing all of this firsthand, got involved in virtual reality very early because of my gaming background, saw it as an incredible solution to this problem. You use it anytime, anywhere, train hands-on with cutaneous haptic feedback. You can train as a team or train remotely, and you can get objective assessment for the first times ever. And so we talked a little bit about, in the previous talk, about engagement and fun, and this is critical. I was just talking earlier, when you're disrupting medicine, introducing a new technology, just working and having something that works is not enough. You need to communicate it effectively and get people to use it. And so part of how we do that is with hyper-realistic, unmatched artistry. So we have a team of Oscar and Emmy award-winning artists, not just to create things that are clinically accurate, but to create something that is jaw-dropping and unique and draw people in and then keep them using it. Hopefully in the spirit of Vesalius, who we don't have enough time to talk about medical history, but change the medical world with the power of art. This is an example of our focus on real-time imaging simulation. So on the right, you're seeing a real-life TAVR procedure, which is transcatheter aortic valve replacement. On the left side, you're seeing this is in VR. This is simulated fluoroscopy. It's very difficult to tell the difference between the two. If there are any interventionalists here, welcome any feedback that you have. Once again, this is our transthoracic echocardiography example. Once again, real-time ultrasound. This is a heart generated from real-life patient CT data. As you can see, works very similarly to real life. Once again, if there are any ultrasonographers in the room, welcome feedback or even to tell me what I'm seeing because I'm a simple bone doctor. One of the things I don't see people talking about enough is it seems obvious that one of the superpowers of VR is to simulate procedures in a near one-to-one way. You're doing it. You're not reading about it. You're not watching a video. You're doing it. But another thing that VR has that just other learning modalities don't have is the ability to connect us one another. Take someone from halfway around the world and put them in the same room as you. And that really changes how we teach, how we learn, and especially how we train as a team, which is, I can't emphasize enough, a huge crisis right now. We are in a staffing crunch, and you're working basically with a different team every single day who maybe have never done orthopedics before, never done interventional before, and you're having to train them in real time during the case. So having a tool like this would be incredibly helpful.
Hey, Leaf, if you could hand me that insertion handle.
So what you're seeing here are two team members in different states jumping together in the same virtual OR. I'd say the one thing that's unrealistic here is how polite they are to each other. OR is quite a hostile environment. And so you can see that anyone can perform any step.
I'll go ahead and slide this in.
The scrub tech is doing the scrub tech steps.
If you could be so kind, I left my mallet on that table over there.
You can move around the room. There's spatialized audio. You can set up different stations, just like a real-life lab. But this is amazing and can truly be done from anywhere. So sometimes people will be like, hey, Justin, we need you right now. Can you jump into this VR training session? I'll pull my car over the side of the road, connect to my mobile hotspot, jump into VR. I haven't been arrested yet, but I get a lot of weird looks. I peek out into the headset, see people staring, but it works. So the title of the talk, we're talking about haptic feedback. So the first thing is, what are the different categories of haptics? So I see a lot of confusion around this, where often when people are being like, what about haptics? They're asking about force feedback, or what's called kinesthetic force feedback. So this is typically grounded kinesthetic feedback, which means it's attached to a surface. So that's in the form of the 3D systems or Geomagic Touch, which you're seeing here. Once again, please check out Happily Robotics device. It is much higher quality and really cool and more portable. It's out there. There's also ungrounded kinesthetic haptics. So if you saw Raphael Grossman's talk, he demoed this with the backpack. This is the idea of an exoskeleton. So if you're grabbing an apple in VR, you feel your hand around the apple. And then there's cutaneous haptic feedback, which hopefully we're all very familiar with because it's in our phones. And it is a very advanced technology. You can feed sound waves through it, do all sorts of things, and available off the shelf with most modern VR systems. So how well does kinesthetic haptic feedback work? So if you look at large systematic reviews, and these are difficult to interpret because haptic systems are implemented differently for different approaches, but these large reviews tend to show that for many studies there seems, for whatever reason, to be no difference in skill transfer with a kinesthetic haptic system versus one with no haptics at all. Now, there are some studies that do show a positive difference, but the difference is minimal, clinically insignificant. So it does improve skill transfer, but to a point that doesn't seem to justify the expense, the increased setup, and the fact that it breaks, and also some of the changes in experience, which is, do people like haptic feedback? Now, it is very possible to create good haptic experiences, but it's hard. And so in this one study, which I thought was really interesting, where you have 20 surgeons, all who think haptic feedback is very important, or 17 out of 20, when they compared a grounded kinesthetic haptic simulator with one that had no haptics at all, 18 out of 20 preferred the non-haptic simulator, which is just very interesting. So, and I'm going to show you an example of this from real life too. And then there is this idea of a negative training effect. If you're telling someone that something is 100% realistic and you train them incorrectly, you could make them worse, which some studies have shown. We also talked a little bit about how much are these simulators being used. So if a simulator is stationary and you have to go to it like in a sim center, the usage is pretty shockingly abysmal. I think this is pretty consistent if you just ask people empirically, but the data supports it. So this is a study out of CU and Penn. They had 30 residents, all who had access to a simulation system, and over a year you had about like one person that used it. So very similar to the study that you showed. So you're seeing this very consistently, that if you can't bring it with you, the likelihood of someone engaging with it is very low. And I remember when I was done with, I was post calls at the hospital for 30 hours. I'm finally on my way out. I can see my friends and my family for the first time in a couple of days. They're like, by the way, swing by the simulation center if you don't mind, while you're on your way home. And I'm like, are you kidding? Like, not only do I want to sleep, see my family, but I might die driving there because I'm so tired. I'm not going to go to a separate building to go train. It's like, it's too much. But at the same time, during those 30 hours, I'll have like 45 minutes or an hour I'm just sitting there not really doing anything that if I had a VR headset with me, I could have jumped in, spent 5 minutes brushing up whatever procedures I had coming up the next day. So how well does our technology work? So that's something we really want to understand as clinicians. You're seeing broad support that VR does seem to work, but I think this video is just like a great illustration of the effect in practice. So what you're seeing on the right is someone trained in OSO VR, trained to a set level of proficiency. On the left side, you're seeing traditional training. This is lecture, technique guide, list of steps. So you're seeing him fly through. It's actually my old program director in there. I never got that handshake. I'm not bitter. If you look on the left side, love you, Dr. Suhu. If you look at that little piece of paper there, that's a list of steps. You can check that if you don't remember what to do next. What's interesting is this guy didn't come in the room until he felt confident to do the procedure. He's like, yeah, I'm ready to go. And he checks this piece of paper 26 times, whereas the individual who's objectively assessed checked it 0 times. And the thing I want you all to come home with is how we feel and what reality is can be shockingly different. And the sad fact is that the majority of healthcare right now is on the left side. It is all, we are making judgment calls. I'm ready to do this surgery. This person is ready to do this surgery, but we are not objectively measuring ourselves or others, and that's the change that we want to see in the world. So in this study that was published in the Journal of Surgical Education, they found a 10-point improvement in the global rating scale, or OSATs, in those trained with OSO VR. This is a study published in Cores, this top 3 orthopedic journal. This looked at the ability to complete procedure without needing supervision. So once again, there's that study from Brian George in 2017 that showed 30% of graduating residents couldn't operate without supervision. So in this study, a traditionally trained group, 25% of that group could operate independently. When using OSO VR, that went up to 78%, so a massive increase. This is a study in residents in fixed-bearing joint, unicolumnar joint replacement. This also found a 6-point improvement in performance score. Procedure time improved by 10 minutes. Redirections went from 9 to 3, so down by 60%. And the training time was more efficient as well. This is something called the transfer efficiency ratio, the idea that, hey, if I'm training in VR, it takes less time for me to improve than reading or watching a video, which has been replicated in the literature. This is a study comparing training in OSO to a video and found that training in VR was better. This is a study in Latin America and 120 practicing traumatologists that found that 93% were willing to use VR as an integrated part of their training pathway. So this isn't just a technology for trainees. And then finally, this is a really interesting study out of Johns Hopkins where they actually pitted OSO VR against training on a physical model. So this is a sawbones, this is a type of plastic we use for training with a soft tissue envelope, real life surgical tools, and a real C-arm. And they found no difference between the two approaches. So once again, very similar to that systematic review, there seems to be no difference in skill transfer between the two approaches, or if there is one, it seems to be somewhat small. This is really cool. This is a motion analysis study out of Wake Forest. Let's see if I can get this video to play for you guys. There we go. So if you look on the left side, you're seeing residents working on a sawbones with motion trackers in this is a pitching lab or motion analysis lab. On the right side, you're seeing the same procedure but in VR. And so as you can see, it's very hard to tell the difference in the group. And so in this study, they had 15 residents. They looked at 64 different motion variables, and 63 were statistically identical between the two approaches, which is wild. So this is currently under review for publication. So I finally want to end on the traditional education journey, which we talked about. If you're doing a new procedure, you're a resident, you're typically reading a book, watching a video. Maybe you have the option to do a cadaver lab, maybe not, and then you're doing your first case very early in your learning curve, and probably the attending is going to take some time before they even give you some sort of so-called reps while they watch you and get used to how you operate. And so the idea of a VR-enabled digital education strategy is that you have the opportunity to practice in VR, not just to work your way up the learning curve, but to demonstrate proficiency so that you can get more reps in sooner and also learn new procedures faster once you're on your own or refresh yourself for old procedures. And I think the reason why I love this graph so much is when I'm talking to people, they're like, well, you can't train people in a video game or in VR. Like, we need to operate on cadavers or on real people. And I'm like, yes, of course. But that's just one rep. And there's a huge gap where we have nothing. And so we're not taking that away, we're just making that much more effective, because wouldn't a cadaver and someone donating their body to us for our education be so much more effective if we knew what we were doing when we showed up at that incredible, important moment, rather than coming in blind? You're going to forget 90% of what you learned within a week. That's just basic adult learning. And so we're not changing the way we're training surgeons or learning, but we're filling a huge gap that we have currently. And when you talk with surgeons or other people in the space, and you're like, hey, we're actually making what we already do much more effective, they're like, that makes a lot of sense. And it's also scalable. So there are over 1 million surgeons around the world performing 300 million surgeons annually. And so we need a technology that we can get to every single one of them. And standalone VR provides that opportunity. A $400 headset you can get from anywhere that is portable, that you can carry with you, you could train every single day. And just imagine 1 million surgeons, 300 million surgeries, each one of those 10% better, 20% better. We're seeing data even larger orders of magnitude. That's an improvement in healthcare delivery that's very rarely seen, all possible with the power of what is ultimately video game technology, which is what's so wild and exciting about this space. So thank you guys so much for your time, for coming to this conference, for your advocacy, because the field is moving forward at a face-melting pace, and I've never seen a technology like this be adopted in healthcare, and it's been very exciting. So thank you for your time.
Thank you. It's really great what you and your